Just a reminder, you are connected. We're just giving folks about a minute to connect before we begin our webinar this afternoon or this morning, depending upon where you are today. All right, folks are filtering in. Just a reminder, you are connected into the webinar. You're in the right place. We're just giving folks a minute, and a minute has passed. Thank you all for joining us for this, our July edition of the Collaborative Family Healthcare Association webinar. This is a great topic this morning. You all are going to really enjoy our presenters. Before we get going, just a couple of quick announcements, and we'll jump straight into the webinar. The Collaborative Family Healthcare Association, of course, hosts its annual conference, and we want to let you know about it. If you like the webinar today, this conference is really full of these sorts of topics and these kind of presenter, this caliber presenter. So our conference is this October 19th to the 21st in Houston, Texas. If you'd like to learn more about this conference, please check out our website, integratedcareconference.com. That's integratedcareconference.com. We'd love to see lots of folks. We're actually showing some really steep registrations right now, so I do want to encourage folks who are planning on coming to make sure they get their hotel rooms reserved to make sure they're as close to the conference site as possible. So that's this October 19th to 21st in Houston, integratedcareconference.com. Also, if you're not a CFHA member, please consider becoming a member or part of the movement towards integrated care. Again, you get to rub shoulders with folks like the folks you're going to hear today. You get to participate in our listserv, where folks like you're going to hear today participate actively, and you also get a discount to the annual conference. So that's a little bit about our association. Let's talk a little bit about the presenters today. I'm not going to belabor their introductions because they are both very well known, but it's helpful to just know a little bit about the presenters so you can feel confident that the folks that you're hearing from really know what they're talking about, and you can definitely feel confident with Drs. Katie Kanzler and Dr. Patty Robinson today. What I most appreciate about their bios and their history is that these folks are clinicians. They're folks who are on the ground working in these areas, laboring every day, and so their expertise comes from lived knowledge. Dr. Katie Kanzler is Assistant Professor of Psychiatry and Family and Community Medicine at the University of Texas Health Science Center in San Antonio. She is ABEP certified in clinical health psychology. She's also the director of integrated behavioral health at UT, at the UT Health Primary Care Center. She's done a bunch of stuff in the PCBH model and has over decades of experience working in ACT as well, which you're going to hear about today. And Dr. Patty Robinson, of course, probably needs no introduction. She's one of the pioneers in the PCBH movement. She's also an expert in ACT, has written many books, and with chronic pain in particular, has done a great job of applying ACT to chronic pain in the primary care environment. She also works as a consultant with Mountain View Consulting Group. So these are your two presenters today. You couldn't have better presenters for this kind of topic today. Drs. Katie Kanzler and Patty Robinson will take it away. One other quick item that I've neglected to mention, if you do have questions, please, as the session goes on, feel free to add those questions. If you have that little GoToWebinar control panel on your screen, you'll see it at the bottom under the webcam part. There's a questions area, and you can type in your questions as they go. The presenters are happy to answer them as they go. We'll also leave some time at the end for those as well.
Great. Hi, everybody. This is Katie Kanzler here, and I have Patty on the phone with me. You want to say hi, Patty? Well, let me turn your volume up. So I'm going to get us started today. I'm really excited to be here and, of course, to be here with Patty. So just want to let you all know that this study was actually supported by a Mentored Career Development and Research Award funded through the UT Health San Antonio. And our outline for today is right here. We're going to cover quite a few different topic areas. And here are our objectives, which we had had on the website as well. So we're going to be talking about why persistent pain is a challenge, how to use population health approaches in research and in clinical practice. We'll talk some about how to get buy-in to do research and other projects in primary care. And we'll also be talking about how to use some specific ACT techniques with patients with persistent pain. And actually, Patty and I are curious to know how many of you out there have experience with acceptance and commitment therapy ACT or focused ACT. And we would like to know if it's none, some, or a lot. And any of you can just go ahead and just type in there what your experience level is. Again, none, some, or a lot. Thanks for doing that. All right, and now we'll talk to you about the problem of persistent pain, which you're probably already familiar with to some degree. So persistent pain or chronic pain is more prevalent than diabetes, heart disease, and cancer, all of those conditions combined. More than 100 million Americans actually have persistent pain, and worldwide persistent pain causes more global disability than any other condition. So, as you might also know, most patients with persistent pain actually receive their care in primary care settings from their primary care clinicians. And probably also not surprising, a lot of primary care clinicians find these patients to be particularly stressful. And for those of you who yourselves work with patients with persistent pain, you might also find them to be stressful because much of the time, these folks really struggle with a lot of different comorbid conditions. There's a lot of complications in their lives. And interestingly, patients who present to primary care with pain tend to describe more pain than patients being seen in tertiary or specialty care settings. And of course, there's also an addiction risk with this population depending on the medications involved. So one of the primary medications that you all probably are hearing a lot about these days are opioids, and they are definitely among the most commonly used pain management tools, even with the different concerns about prescribing them, such as significant side effects are involved, like GI upset, dizziness, physical dependence, tolerance, respiratory depression. These are some of the possible side effects patients with pain can experience. And you also have pretty severe withdrawal symptoms that people might experience if the medications are discontinued. And those symptoms can include nausea, vomiting, sweating, joint aches, agitation, tremor. So this is a really serious problem. Unfortunately, compared to other specialties, in primary care, opioid prescriptions actually increased more than 7% from 2007 to 2012. So not heading in a direction we would hope. And in addition to all the side effects and withdrawal symptoms and risk for dependence, the opioids don't actually necessarily work. So research has shown the benefits over time really aren't so clear. Patients on opioids don't always have better pain control. They don't always actually get the improved functioning that they're looking for. And some people who are on long-term opioids actually experience increased pain. So the opposite of what we would hope for. There's really a need for multidisciplinary or whole person treatment. And another term for that, of course, is the biopsychosocial approach. And you can see with our little graphic there on the lower left, kind of a simplified version of that model, where you can't just treat the body part of a person, which is really that medication approach. Because we know that pain affects and is affected by not just what's happening in the body, but also what a person is feeling, what they're thinking, how they're behaving, and what's going on in their environment around them. So the typical medication-only approach is, even when it is effective, is actually only targeting one area of the person. So, what can be done? Well, there are evidence-based psychological treatments that can reduce disability. In fact, the Centers for Disease Control actually specifically recommends that, and they explicitly recommend cognitive behavioral therapy techniques. So ACT is a cognitive behavioral type of treatment with strong evidence for people with persistent pain. And ACT improves physical functioning, it decreases distress, and it does that through a few mechanisms, including helping patients increase their acceptance of their pain, helping reconnect with values and what's important to the patient, and focuses on reducing things that we do that might be unhelpful to try to control the pain. Unfortunately, ACT, like most psychotherapies and psychological treatments, tends to be provided in specialty care settings. And that's really unfortunate because it means people are not accessing ACT who might really benefit. Because, as we said, most patients with pain come to primary care for their treatment. And just a little bit on ACT. For those of you who are not aware, and Patty will talk a lot more about this later, but in the ACT model, there are these 6 core processes, and as you can see here on this slide, that top one is contact with the present moment, or as Russ Harris says, just being here now. Another important component of ACT is the focus on values, or knowing what matters to that person. There's a committed action component, or doing whatever it takes to stay connected to values. Then there's the self as context, or this concept of being totally aware of your experiences and understanding that you are not your thoughts, or you are not your pain, that you're separate from them, and you're the context for these experiences. Another process, a core process in ACT, is diffusion, or watching your thinking, literally diffusing from thoughts, especially thoughts that are getting in the way of living a valued life. Then, of course, there's acceptance. And so acceptance can be defined a lot of ways. I like this, just open up. Acceptance involves willingness as well. And so at the heart of ACT, it's producing psychological flexibility, or being present, opening up, and doing what matters. If that's a little bit too much to try to remember, then I really like what Patty and Kirk have put together with FACT, focused acceptance and commitment therapy. And you can see here the simplification of just having 3 pillars, that being open, being aware, and being engaged. So if you can't remember all those 6 core processes, see if you can think about just these 3 as we go. So back to this problem of, we know that ACT is a potent treatment option, but it's not necessarily available in the location where most people are seeking care. Enter the behavioral health consultant. So behavioral health consultants in the primary care behavioral health model, they might be the key to helping to deliver this kind of care. Because we know there is ample evidence, or I should say growing evidence at this point, that BHCs can enhance that whole person treatment approach through delivering brief treatments. They're effective, they are evidence-based, and they're non-pharmacologic, of course. I have a few citations there, but there are actually quite a number more at this point. Although the literature is growing as far as the evidence for effectiveness of BHCs, persistent pain in particular hasn't actually been studied. So there's a little bit of a gap in the literature there. And ACT can certainly be delivered in the PCBH model. In fact, to those of you listening, maybe some of you are already doing ACT. I know for the many years of being a BHC, I have been doing ACT already, or actually FACT, but we just haven't studied that yet. However, I should say Lance McCracken did study ACT delivered in a primary care setting, but that was not an integrated care setting, and it involved 16 hours of treatment. However, that was effective, so it's certainly promising. So yeah, clinics may be, clinics with the BHCs might be a great place to access ACT, but we just don't know, is this effective? So we set out to study this, and here's kind of our official aims and hypotheses, and just to kind of briefly review those. The goal is to determine the feasibility and effectiveness of ACT delivered in this setting. And we are, thinking here, we are, hypothesis is that this brief treatment will reduce physical disability, and medication misuse in patients with persistent pain. And this is in the context, of course, of team-based primary care. So even like with this next aim, looking at mechanisms of change in patients receiving ACT, this is not the same as some studies out there that are very, very controlled trials where you're just looking at the psychological intervention. Because in this study, it's happening in the context of the PCBH model where patients are obtaining care in primary care, and the BHC is supporting that overall treatment plan with ACT techniques. All right, so a little bit about the methodology then. And we wanted to mention this not just to give you information on the study, but to explain a really powerful way of doing clinical care as a BHC. So population health can be defined in a lot of different ways. And I like this definition here: the health outcomes of a group of individuals, including the distribution of such outcomes within the group. So population health is not concerned just with the people in your clinic's waiting room, or the patients in front of you, or just the folks in the exam rooms. The entire population needs to be cared for with this population health perspective. So this is really happening a lot in different primary care settings right now. Another way to think about this from a BHC perspective is that oftentimes the work that we do as BHCs involves a horizontal integration, meaning you see everybody that comes in the door. You might see somebody who is dealing with obesity, or chronic pain, or depression, or anxiety, or insomnia, or any number of concerns. And these patients can be from all different demographics as well. That's kind of that horizontal perspective. But with a vertical approach, which is similar to collaborative care models where you're just focusing on one patient population, that is also highly compatible with PCBH settings, because it can be very important and critical, in fact, to target specific patients who might be at risk or who are who could really use some prevention or other type of intervention. So that's that vertical piece. It's sometimes called a clinical pathway. So hopefully that's not a completely foreign term to many of you, this concept of a clinical pathway where you're targeting the patients who do have insomnia or have depression or a specific other concern. So I know when I was active duty Air Force and being a BHC in that setting, the DoD did, and they still use a lot of clinical pathways throughout their clinics. And this is quite helpful in, again, reaching a patient population that might not just be showing up at your door, but that would really benefit from additional services. So this study is targeting the specific population then of patients with persistent pain. Oh yeah, and here's our little graphic. So kind of what we're doing in this study, we're identifying these patients, the potential participants, we're screening them, we're assessing, and then of course, we're acting. So the setting of this study is in San Antonio, Texas, in a family medicine clinic. It's also patients in a medical home. And the whole team includes quite a number of different disciplines, as you can see here. And there are currently 4 of the primary care clinicians. Over 6,000 patients, and most are female at this time, and about a third are Hispanic Latino. You can see our inclusion-exclusion criteria sort of broadly laid out there. We actually wanted broad inclusion criteria to allow for greater generalizability. You know, this is a real-world study, and we wanted to be able to capture as many people as possible. So if you're an adult and you have non-cancer pain that's lasted at least 3 months and you're currently at the clinic, pretty much you'd be eligible. And that we started out by saying you had to be on opioid medications, but we realized that this treatment could be quite useful for people who are not on medication but have persistent pain, or those who might be thinking about taking medication. Maybe it can serve as prevention in some ways. And then here are the actual steps. So we're right now in this in these first sort of few steps where we're identifying patients through the electronic health record. We've started to build a registry of patients who meet our study criteria, and we have started recruiting. And so we're recruiting in a few different ways. And again, this is extremely similar to what I've done in the past in primary care clinics for just clinical services. So we do have advertisements hanging all over the clinic, but we also have this registry where we've sent secure messages through the electronic health record, which for us is EPIC. So we've been sending messages to patients to invite them to participate and let them know about the study. And we've also been sending letters to some people who aren't enrolled in that secure message system. We're doing follow-up calls as well. And then we move into the screening and actual enrolling. In our calls, we're doing pre-screening, enrolling. I should say too, of course, we get direct referrals from our primary care clinicians as well. Again, pretty similar to regular clinical practice. Then we'll bring our folks in for baseline assessments. At that time, they'll be randomized to one of these 2 groups, stratified based on their pain severity ratings. And just a little info, some data here. Patients who have been seen in the clinic in the last 30 days, so they actually had to come in and be seen in the clinic, we had over 700 who presented with some kind of persistent pain issue. And of that group, about 26% were taking opioids. So not just taking, but having active prescriptions again, and also seen within the last 30 days. And here's a little bit more on the treatment flow, and Patty will talk a lot more about that, but we are going to have in the active group is the folks who are going to be seeing me for a BHC visit. Then they'll have class. You can see their class 1, 2, 3. Those are all weekly, about an hour long, and then they'll come back in 2 months for a booster class. And while that intervention is happening, the individuals in the control group are going to have what we're calling enhanced care, and they will be receiving handouts based on cognitive behavioral science that are proven to be helpful for managing persistent pain. So information on pacing, sleep, relaxation, setting goals. And again, we'll let Patty fill you all in on that intervention a little bit more later. Actually, I was looking here, I didn't see anybody write in, but maybe I'm looking at the wrong spot in the chat. But if anybody happens to have any questions for me about the study at this point, that would be great if you want to throw them in there. And I'll try to answer them before we move on to Patty. And just to let y'all know too, here are the study measures. We're looking at opioid misuse, on pain acceptance, on connection to values, on patients' ratings of their disability, their pain severity. We're also looking at self-compassion. And then in regular clinical practice, we're going to gather the data from the health-related quality of life measure by the CDC and the PHQ-9. So a few tips for getting buy-in. This goes not just for trying to do a research study, but really any kind of new clinical program or any kind of a QI project. Lots of communication. An unbelievable amount of communication is really helpful. Always talking about, too, your ideas, what the rationale is for this idea, what the cost could be, and, of course, what your expected outcomes and benefits might be. Have your medical director or clinic director on board from the start, if at all possible. I know I was really, really excited to have that for this study. And so my medical director is awesome. She thinks pain is a problem too, and I was really excited about this project. So that really helps to get the leadership of your clinic and above your clinic, if needed, involved. Keep when any kind of designing any kind of project or clinical program, it really helps to keep the workflow impact as minimal as possible. Same goes for the clinicians and staff. If you're going to come up with a great idea, but it's going to have a tremendous impact or interruption in the daily business of the clinic, that's going to be kind of hard to sell. Also, find your champions. So who, in the clinic is really excited about, your project or idea. That's going to be invaluable. I think I have a mystery champion right now, in addition to some known ones, because I went into the restroom the other day, and inside the restroom there were flyers as well, which I didn't place. So I thought, well, that's cool. Somebody's really excited about the study and is hanging the flyers all over. So that really helps to have those champions. Being creative kind of speaks for itself when you're coming up with these ideas. And I would say a really important tip is to feed the people that you're working with, especially when you're trying to get buy-in and kind of sell a new idea. So know what your team likes. It's worth a personal investment in providing food or coffee. I'd say lots and lots of coffee has also been helpful. So that is it for my section here. So I'm about ready to turn it over to Patty. I don't see any questions yet, but we will also have some time. Oh, wait. Maybe we do have questions. No. Okay, I don't see any, so we'll come, if I'm just missing them, we'll have a little bit of time at the end as well, to be able to get back to that. And now, Patty, I'm going to turn this over to you.
Okay, thanks, Katie. How does it look in terms of the experience level of people listening in today and with ACT or focused acceptance and commitment therapy?
So I cannot see that, and I'm not sure if it's because nobody has typed in or because it's not something that I'm able to see.
Yeah, so you can see it on the questions tab, and most folks have indicated some or none as far as experience.
Okay. And thank you. I'm in the questions tab and I don't see anything, so if you could jump in again, Naftali, if we're missing anything, that would be great.
Yes, and I'll just remind people, if you want to ask the question, you actually go into the chat area and ask the question there. The question area is just for answering questions from the presenters. So go to the chat area if you have questions and type them in there.
Great. Thank you. Okay, Patty, you're on slide 1.
Okay, great. I want to focus on going over the intervention in a little detail just to give you the flavor of it, and then try to teach you 2 things that you could use this afternoon with patients that you might see with persistent pain. So Katie and I worked really hard on the manual that will be used in this randomized controlled trial because we wanted to be immediately available to people if it is helpful. So it's a pretty extensive manual and lots of scripted kinds of exercises for BHCs to use. Every class has a mindfulness exercise as well as other exercises accompanied by worksheets. So our goal was to try to create a product that would make it very easy for someone with minimal or moderate level experience with ACT to take this manual and put it into action. And that's because this is such a big problem, and we want to help make a difference as soon as we can. The intervention starts just like it'll start in your clinic this afternoon, where somebody refers a patient and the BHC has a visit. And in that visit, there's an orientation to the program, an overview. There's an orientation to the biopsychosocial model. And there's the introduction to the matrix, which I'm going to introduce to you in a few minutes. But it's a very simplified form of the matrix, and the focus is on, in terms of homework or practice kind of exercise between the BHC orientation visit and the first class visit, is on writing a couple of paragraphs talking about their values, specifically responding to 2 questions: what matters to you or who matters to you, both or either one, and to kind of bring that to the first class meeting. I want to explain that we want to make the classes open access. So while it's been a challenge for Katie and I to kind of think through the details and minimize the hierarchical nature of the content of classes, patients will be able to enter into a class the same week or the following week after the BHC visit. So we talk about class A, B, C, and patients do not need to have attended A before attending B or A and B before attending C. They can start at Class A is the focus, and again, each class is kind of grounded to some extent in the focused acceptance and commitment therapy model. So there's more information for the PhD to kind of think about. But what we're really working on in Class A is looking at values and action and the connection between the two. And with what we say, establishing a stronger sense of caring about either something or someone and making moves in the direction of that caring. So we talk about caring moves. And I think towards that end, I would like to just maybe quickly give you the flavor of one of the exercises
Patty, could I pause you right before you do the exercise? Because we're having a few questions come in. And
okay.
One of them is, where can we access this manual? And you and I had talked about that. So this manual is not yet available because we are testing it, because we need to see if if this is a good combination of skills training and exercises and information. So we are not going to be releasing that until after we finish this study, but we hope that we have good findings, and at that time would certainly want other people to use it. And then there's another question about, are the interventions weekly and for how long? And the interventions are weekly. The visit A, B, and C are all weekly, about an hour long. And the booster comes in 2 months, and that's also an hour long. And someone else was interested in the PowerPoint, and yes, I think that's going to be available. So those are some of the questions, Patty. I'm going to let you jump back in with the exercise.
Okay, great. All right, being mindful of time, I'm going to skip forward with a couple of slides. As I said, we use the matrix throughout. And the matrix, I want to be sure and credit Kevin Polk and his colleagues, Benji Schoendorf and Dr. Ola in Argentina, Fabian. Very helpful kind of resource there, and I recommend that you look at that book. On the next slide, you'll see the matrix, and we have different versions of the matrix that we use in each of the classes. This version on this slide is the one that's used in the orientation visit, where we introduce the model and kind of work through the patient's sense of frustration and discouragement with having tried so many things to cope with pain and not really coming up with much that's working. And so we introduced this idea of my life on the matrix, so developing a new perspective on their life and the role that pain is playing in it. So as you can see, there's a horizontal and a vertical line, and in the middle we have the me observing bubble. So we talk about that capacity to observe, and if you think back to the fact pillars, that's the center pillar, that horizontal line. So that's the aware pillar. You have open, aware, engaged. So at the top, you've got what I can sense, and at the bottom, you've got what I think, feel, remember, my emotions. That sense of being present in the moment, having perspective on yourself and what's happening. So fundamental to making quick little changes in the way that we're living and making decisions moment by moment. moment in our life, because it's very hard when you're presented with the ongoing problem of pain, and we tend to make a lot of away moves from our values. That horizontal line on the right hand side would be kind of what really matters to the person, and on the left hand side we talk about away moves. We move away from what matters in order to shut down the pain and the way we experience the pain. So let me talk about that. So we have a lot of unhelpful thoughts and feelings, like pain is bad, pain is dangerous, and then we have unhelpful behaviors. These are often distractions, things that we do to get away in the short term. Alcohol, smoking, even pain pills, rescue pain medicines. If they're done in a way to just get away, can move us away from what really matters. And many of you are probably thinking about patients who've seen that have suffered with persistent pain for decades, and their lives may not at all reflect what really matters to them. So in that initial BHC orientation visit, we're in that bottom right quadrant, and we use the bullseye with the patient to help them identify their values in one of these four areas: family, work, health, play, spirituality. And then again, they are going to write a little bit about that. We talk about the connection between values and the top right quadrant there, where we have goals that are consistent with our values, and we have plans that are action plans that we make. I'm going to move to the next slide and talk for a moment about the bullseye. This is was the creator of this wonderful ACT metaphor is Tobias Lundgren from Sweden, and it's very helpful. In fact, I used this metaphor in a book called Real Behavior Change in Primary Care with a variety of problems, because it really allows you to work all of the pillars or all of the points in ACT, and to take a team-based approach. So there are free chapters on using the bullseye that you can get off the internet, because we didn't even put them in the. So you can get a flavor for using this tool, which really involves kind of drawing the concentric circles. You don't have to have a handout, and inviting the patient to think for a moment about what value is most important to them, and then to see that value as like the bullseye. It's not like something we hit all the time like a dart when we're not hitting the bullseye, but it directs our focus. Particularly if we kind of call that to mind, that value, that principle at the beginning and ending of our days, and maybe set one small goal every day to try to get us on target, not to the bullseye, but on target. And then to be curious about what is it that gets in the way when we try to do that one thing. And then as BHCs and PCPs and nurses, we can teach them skills to help them address the barriers that show up when they try to make that value consistent action. So that's one thing I hope you'll experiment with after the call today, is using the bullseye and just really connecting with a patient about their values in a particular area of their life, and helping them set up one behavioral plan to get them on target. And then at follow-up, exploring barriers. Now, this next slide is kind of it's the matrix that we use in what we're calling the pain and quality of life pathway. And you'll see some of the other content there. So the bottom left quadrant, where we have STEM, these are sensations, thoughts, emotions, memories that are unhelpful in terms of moving us toward what we really care about and want to do with our lives. And then top left quadrant are what we call the dots, and those are distractions, opting out, thinking, where we're just thinking, ruminating kind of thinking as a way of avoiding kind of what's happening for us, and substance abuse and self-harm. So these are behaviors that are unhelpful. So what we are trying to do is help the patients, and by the way, patients with persistent pain are not the only ones that have STEM and dots. Mm-hmm. We all do. I do. Katie does. Mm-hmm. So it's a matter of recognizing them and developing a new relationship with them, a more mindful relationship with them. And we have a lot of things in the manual that help them kind of systematically use worksheets, develop greater familiarity and more self-compassion and kindness towards themselves in recognizing and responding to these STEM and dots sorts of things. So I think at that point, we'll turn it back over to Katie to summarize a little bit, and then we'll have a little time for questions.
Great. Thanks so much, Patty. And I do want to take a moment to answer a couple more questions. The question about no-show rates. And so we have not started the groups yet. So we're still in the enrollment and advertising and pre-screening stage. So we're hoping, though, we've done a few things to help to anticipate that problem with that can happen. And I should mention, too, for the assessment visits, those are quite long, and the participants will be paid to come in to do the assessments. But the classes, the groups, there is a fishbowl drawing, we're calling it, which is consistent with some of the types of techniques you might do in clinical practice, where we're doing a drawing at each one where a participant can get, it's basically like a $10 gift card. So that's actually similar to what happens in our diabetes management class right now, which is not research-based at all, where they can, like every time they come, they get a raffle ticket for a prize, so to speak. So there are, these ways that you can try to incentivize attendance. Of course, that's not always possible, but we're gonna see how it goes. And then who's leading the class? Right now, that's me. It's not really ideal to have the PI be also the interventionist, but that's what we're doing because of funding constraints, and also it's a pilot study. So those are a few questions. So, okay, summary. I realize that Patty and I have kind of breezed through an awful lot of information, but here's sort of a snapshot then. So we've talked about how prevalent and difficult persistent pain is, and how most persistent pain care is actually provided in primary care. We talked about ACT being an evidence-based treatment, and that BHCs are really well positioned to deliver FACT interventions, in primary care. And not only BHCs, actually, as Patty kind of mentioned, PCPs and other people in the clinic who have contact with patients are all able to be trained if they're interested, and can really help with the patient care if everybody is able to provide some FACT interventions, if everybody treating the patients. And this pilot study is just underway. So again, really early stages right now. And the design of the study is such that it kind of mimics population-based care and the framework that's already set up in my clinic and in an awful lot of clinics as well. And we definitely, one thing I've noticed too is the excitement of the primary care clinicians about their patients getting this care. Well, of course, we actually have a BHC service there separate from the study. And so that to me means that having this type of pathway and focused approach can help to kind of remind and bring to light for the clinicians that, hey, don't forget, you don't forget BHCs for these other types of conditions. Sometimes the referrals might be more focused on mental health concerns instead of all of the different conditions a BHC could help with. So we also talked about being thoughtful about certain methods to get buy-in for new projects or programs. And then Patty touched on the bullseye and the matrix, and those are transparent fact interventions that really help to promote team-based care. And I would just want to foot stomp too on the bullseye is so awesome. I mean, in almost every visit, it seems like almost every visit, the bullseye comes out at some point because it really does help to support the patient's overall treatment plan in the clinic. And I'm excited about using the matrix more because that's a little bit more of a new technique and tool. So we want to acknowledge our whole team. There are quite a lot of people that have been involved so far in this project. And since we had our bios up and mentioned our interests in our values, some of them are our little dogs. So you can see on the left there, Patty and Kirk's Puggles, and my little pug right there as well. And finally, this is our contact information. Again, I know that we really whizzed through a lot of information, but if any of you do have questions that we haven't been able to answer here, please let us know. And we do still have about 5 minutes if anybody wants to throw some questions into the chat box there.
Yeah, and while people are posting any questions they have, what we can do to facilitate folks getting some of I know folks are probably dying to get their hands on some materials and maybe the bullseye sheet. We can make those available on our social media platform. So if participants want to look in the next couple of days at our Twitter feed, our Facebook feed, or our LinkedIn, we put the same stuff on all those feeds. And if Dr. Kanzler and Robinson, Dr. Robinson, give us any links to materials online, we'll post them there. So check those if you want some sort of ongoing stuff.
Yes. Yeah. In fact, Patty and I talked about this. So even though we're not ready to release the manual, we have those 4 handouts that we're using in our control group. And those are really great resources, so we can certainly make those available. And the bullseye would be awesome too.
I can. I have a chapter on bullseye with chronic pain, and the bullseye tool that I can make available. I'll put together something and send it along. Also, I'll just say that I've been working a little bit with some folks in New Zealand, and a physician at the University of Auckland has put together a brief kind of stacked online training, and so it is free, and I did post or add. I had David Bellman posted for me this morning information about that, so people that are listening in can check on the Collaborative Family Health listserv for that link.
I saw that, Patty. So it did come out, yeah. And we have a couple questions rolling in.
Okay.
One is, have you observed that labeling the behaviors, thoughts, feelings as quote, unhelpful, might that activate shame?
I think that a lot of chronic pain patients have tremendous shame.
Mm-hmm.
But that it would be labeled in the context. It depends upon the context.
Mm-hmm.
So I think that context is developed within the matrix, and so it's in the values, in the context of the person, their values, and what they want to do with their life, and what helps them do that, and what doesn't help them, what gets in the way. So it's a very practical kind of definition of unhelpful that needs to be done in the context of working with a patient on their values, clarifying the values, helping them connect with them. So it's really their description of what helps.
Yes, I was going to say that. Right. The clinician, the BHC, is not labeling. it's the patient would be themselves labeling behaviors that way. And there's another question here, Patty. Was it deliberate to write a manual that does not require significant experience with ACT and mindfulness? Most mindfulness manuals I've seen suggest a personal practice from the provider for the sake of modeling.
I would recommend that too.
Yes, absolutely. Yeah, absolutely. I think what we wanted was that somebody wouldn't need to have a dozen years of experience with ACT to be able to do this. Otherwise, the generalizability and scalability and the dissemination is very, very limited. The techniques and the information are more on the simplistic side, and absolutely, ideally, would also be getting practiced by the provider. I don't know if you have anything else to add there, Patty.
Yeah, and I just more we see how brief experiences and brief kinds of mindfulness practices make a difference in how our brains work. So I think letting our patients know that 5 minutes, 10 minutes makes a difference. We'll get more people practicing exercises that really train their brains to work differently.
Mm-hmm. Great.
And talking about our experiences with mindfulness or brain training, I think we have to language it in a way that's engaging to patients. Some people would never meditate. Mm-hmm. Some people would visual imagery exercise. Mm-hmm. Some people just concentrate, or so we find the language that connects with the patient's worldview.
Mm-hmm.
Great. Thank you very much, Drs. Kanzler and Robinson. A great sort of teaser intro that hopefully gets us all really interested in learning more about ACT and FACT as it applies to pain. And we look forward to hearing the results of this study down the road. Certainly, we will be keen to see what you guys come out with. Thank you to all the attendees as well. Again, we'll try to coalesce some of these resources from Drs. Kanzler and Robinson for you and post them freely on our social media channels. So check Twitter, CFHA, or LinkedIn. You can use the hashtag CFHA or just search for us, Collaborative Family Healthcare Association, and you'll find links and other stuff that we can disseminate to you guys today. Thanks again for joining us.